All right, so we're very happy today to be joined by Melanie Spenceley, who is a nurse practitioner with the Regional Palliative Consultation Team. Melanie, I'll hand it over to you now. Thanks so
Thanks,
much for
Carl.
being here with us.
Yeah, no problem. Hi, everybody. Um, Thank you for coming tonight. I just wanted to say thank you to Carl and Val and the Champlain Hospice Palliative Care Program for setting up the Dining to Learn series again this year and for having me tonight. So my name is Melanie. I'm a nurse practitioner. As Carl said, I work in the Ottawa area with the Regional Palliative Consultation Team. When I'm not working, you can usually find me at a local rink. As I was just saying to Val and Carl, my 3 kids are all playing hockey and keeping me quite busy in the evenings and weekends. Tonight, I'm presenting from my home, which is in Riverside South in Ottawa. And I just want to acknowledge that I'm presenting tonight from the traditional and unceded territories of the Algonquin Nation. So for tonight's presentation, I'm going to go through 3 common GI conditions that we see a lot in our palliative care and end-of-life patients. So I'll cover tonight nausea, constipation, and briefly on dysphagia. I also will pull back then into a part 2 where we can look at how we can support some of the changes that we see at end of life around eating and nutrition. And, you know, having listened to Emily's presentation, I'm hoping this will reinforce some of the points she made and also maybe lay some groundwork for Ali's presentation next month. So our GI system is almost all encompassing. It's like tip to stern, as I say, so to speak. It starts at our mouth, which is our entry point for food and fluids when we ingest them. They're chewed and mixed with saliva to form a bolus. That when swallowed transverses down the esophagus. So that's that long pipe that connects to the stomach. In the stomach, any intake is sort of doused in a mixture of acids and fluids to start the process of digestion. The stomach then empties into our intestines. The small intestine is responsible for absorbing a lot of nutrients out of that wash of food and fluids that's there. It breaks down the food further and it sends like waste and unused portions of the food on down into the large intestine. As that fluid transverses through the large intestine, all of the water that's in there gets reabsorbed back into our system to use. And the byproduct of that is of course, a bowel movement or stool. The final exit point being the rectum and anus. So from start to finish, our GI system encompasses a lot of different areas. And as such, there's a lot of different pathologies that can come with it. This is by no means an exhaustive list, but going from mouth through to the bottom, there's a lot of things that can go on in the GI system and affect the way that we're feeling. So nausea is the first symptom or the first condition that I'm going to talk about. It is the unpleasant sensation of being about to vomit. It can come with or without other associated symptoms. So for example, you may have a bloated stomach. You may start to have that watering feeling in your mouth or a water brash where there's some gastric contents that come up and mix with the saliva. You may get the sweats or feel pale. Nausea is a really hard symptom to control, not gonna lie. It's one that's sort of a bug in our side sometimes. And the reason for that is there's so many different causes. So as we go from mouth to bottom, all of those things can contribute to the cause of nausea. If we can narrow down the cause, then the intervention will be focused and hopefully more effective. So there are four main sources of nausea, or sort of causes of nausea. We have chemical, so that's in the chemoreceptor trigger zone, which is located in our brain. Things that affect that CRTZ is medications, chemotherapy, for example, toxins. So when our kidneys aren't filtering as well and we're having different metabolites building up, that's going to affect that chemical zone in our brain. We have the vestibular system, which is what would happen if you were getting motion sick, for example, or on a merry-go-round. Vertigo would be another good example of that. The cortex, so that's the surface of our brain, is where emotional factors can trigger nausea. So for example, if you're feeling anxious, if you smell something that turns your stomach a little bit, if you have an emotional response to someone or something. For example, patients who have to go to the chemo treatment unit, they know they're going to be sick or feel crappy from the chemo. They might even feel nauseated before they even get the chemo because of the way the cortex of their brain is receiving that signal. And then finally, there's, I sometimes refer to this as more of a mechanical cause, but it's like that visceral and serosal tissue in our GI tract that stretches or gets irritated as a result of things like tumors, obstruction, constipation. So these are the four causes that we hone in on when we're looking for our treatment interventions. I'm just going to take a quick sip. When we're assessing, and for almost any symptom, I usually use our OPQRST mnemonic, and it can be applied to nausea, no problem. So determining the onset, so when did it start, provoking or palliating features, so asking what makes you feel nauseated, or what makes the nausea feel better, right? So provoking or palliating features. The quality of the nausea, if you can suss that out, that's a bit difficult. The radiating mnemonic probably isn't applicable for nausea as it is for pain. Severity. Is this impacting with your day-to-day life? Are you able to eat? Can you take your pills because of the nausea? So sussing out how bad the nausea is. And then the timing. So is this always happening at nighttime? Is it always happening when you're turning in bed, or when you're receiving care in bed, or repositioning, for example? You're going to look at your patient. You want to observe them. Are they burping or, having like some of those refluxy type symptoms? Is there excess saliva? Is there a refusal of food or pills or other activities because of this? And finally, in terms of a physical exam, you're listening for bowel sounds, of course. You want to look or feel the contour of their abdomen. Are they bloated? Can you palpate anything in there that's hard, like a mass or even stool, for example? Does the palpating elicit a response? Does that cause some nausea or make them feel like they're going to vomit if you palpate? You're going to look in their mouth, right? So something as simple as thrush or poor dental care, or food in your teeth that's left over, that could cause nausea. So you want to really look in their mouth as well as part of your physical exam. And then, of course, our intervention. So we always start with non-pharmacologic. I put a picture of thrush. You can understand seeing that thick white plaque that's not only on the tongue, but the back of the oropharynx, how that could cause some nausea for sure. So in terms of good non-pharmacological interventions, you're looking at good oral care. So ensuring that there's no thrush, that teeth are being brushed, dentures are being brushed, and the mouth is nice and moist. You can eliminate strong odors. So the smell of food cooking, for example, opening up the windows and getting some nice cool air into the room. If the patient's able to eat, you want to present just small portions. A lot of patients, when they're nauseated, are going to become very overwhelmed with a big presentation of food in front of them, and that may even stimulate more nausea. You could think about reducing their diet, even going as far as saying, let's just reduce to clear fluids for now. And as the nausea comes back under control, gently reintroducing or advancing the diet. Some limited data on the effective aromatherapies or acupressure, but I do know, and I have seen this used in long-term care. And despite not having like really robust data, I think when you look at the potential risks of using these types of modalities versus the benefit, it could definitely be worth looking into. Does anybody, and you can snap this into the chat and Val's gonna take a peek because I'd love to collect pearls if you had any other non-pharmacologic interventions that have worked for you in your experiences, either with patient care or yourself. I'd love to dash them into the chat so we can review them maybe before we flip to our next topic.
I've heard lots of people talk about ginger, Melanie, like ginger candies. Not so much, like I know there's a Gravel ginger product. I haven't heard people get good response to that. Jeanette just actually mentioned in the chat ginger ale.
Yeah. I've heard of the gingers as well. Yeah, for sure.
Lemon and hot water, Joanne said. Cold foods versus warm foods and not fatty foods.
Yeah, that's fair. Yeah. And I feel like there's such a spectrum of nausea. Like some people probably or definitely live with this low level of nausea and go about their day to day. And then some people have this like severe nausea where even looking at food causes them severe distress, right? So nothing's going in. So there's a pretty broad spectrum of how people feel with this symptom.
A few others have come up as I was muted there. Yogurt, very specific ginger chews from Winners. Peppermint tea, hot tea. Pam suggested sniffing an alcohol swab for acute nausea. I've never heard of that one.
You know, I've heard of that, and I'm not sure sort of the science behind it, but I have definitely seen people rip open a swab and sniff it. Not in the context of my day-to-day patient care, truthfully, but I've definitely seen that. And I remember when I was pregnant, actually, they had these candies that were super sour candies meant for nausea. And I think I think when sucking on candies, it stimulates some saliva, moistens the mouth up and whatnot, and yeah, and certainly low risk, right? So let's flip and we will talk about pharmacologic, and I'll just put my disclaimer out. I did try and use all generic names, and this by no means is a substitute for consultation with your prescribing counterparts. So really the take-home message and why I talked about those 4 different causes, so the mechanical, the cortical, the vestibular, and the chemical, the chemoreceptor trigger zone, all of those areas have sets of receptors that sit in there, right? So we target the medications to sit on those receptors, depending on the cause, And if we can determine that, then we can make a better selection of antiemetics. So I just did up this quick chart. For example, if we think about starting a new medication, so, opioids, they're very well known for causing a bit of nausea when we're initiating a new dose of opioid or a new opioid. So if we think about the area that affects, that would be a chemical stimulation in the chemoreceptor trigger zone. The receptors that are sitting or active in that area are dopamine, the 5-HT3, which is serotonin, histamine, and acetylcholine. You don't need to know all of that, but know that our medications that we would select are really targeting some of those receptors. So metoclopramide, for example, is targeting the dopamine antagonist receptors and is our first choice when introducing an opioid or combating opioid-induced nausea and vomiting. Similarly, in the GI tract, so if a patient's stomach didn't empty efficiently and that was causing nausea, also we're looking at a dopamine receptor, a 5-HT3 receptor. Again, metoclopramide might be our first choice because it's going to sit on that receptor and help. When we think about the vestibular system, so motion sickness, this is what you would get if you're car sick, right? You're going on a road trip and you're car sick. That's the main receptor in that area is our histamine receptor. So we're going to target more antihistaminergic properties. So that's your Gravol, perhaps something like Benadryl could help with that type of nausea. And then when we think about the psychological stimuli, so that patient that just drives past the hospital, remembers what her chemotherapy was like and gets nauseated, we're sort of going to focus more on that anxiety component or stopping that interaction. And we tend to use actually benzodiazepines for that. So something like Ativan, clonazepam. So when you're looking at the medication choices, it's not a one-size-fits-all. We need to know what the source or the cause of the nausea is before selecting that medication. You definitely want to be thinking about the side effect profile, and especially in our older population, something like Gravol may be quite sedating for patients. And if we know that it's only like super fantastic for that vestibular system, then maybe we reserve it for that type of nausea versus using it as a one-size-fits-all. We also want to look at comorbidities. So one thing that we see often as a comorbid condition that can affect our choice would be something like Parkinson's disease. In Parkinson's disease, we know that there's a lack of dopamine. And so I probably wouldn't select a medication that had anti-dopaminergic properties because I'm going to make those Parkinson's symptoms worse potentially. So things like that require a little bit more consideration into what we might choose. And finally, we also need to look at the route. If somebody is vomiting or sick, it's really hard to ask them to take a tablet for sure. So we want to look at other routes that are available, whether that is subcutaneous. Sometimes we could use a sublingual route. There is some formulations of ondansetron and olanzapine that are oral wafers. So they just sit in there and dissolve so they don't have to swallow. And even a rectal route could be an option too. Okay. This is just another picture to help you think about the 4 different types of nausea, where they're affecting, and the type of medication you might select to combat that. So I always want to try and finish with some pearls, and I often think when I share my pearls, I get like 100 times more pearls back, which I've just gotten in the chat box from you guys. But just a few things to remember in terms of nausea. I usually try a first line agent for about 48 hours before reassessing. So I want to give it a good try. I don't want necessarily to do one and done. So a one dose and then assume it's going to go away. Unfortunately, with our population, a lot of the times the underlying source will never really, or it will be very difficult to correct. So they may need ongoing management of their nausea. So 48 hours and then reassess. Always consider that underlying source of nausea and work hard to reverse it if possible, right? So the big one I often think about, which we'll talk in depth about next, is constipation. If I know my patient's constipated and all of a sudden they develop nausea, I'm going to work really hard to get their bowels moving because I suspect that the nausea will follow suit once those bowels are moving. Similar to oral care and thrush. I'm going to work really hard to get that thrush treated and prevent it from happening again if I know that that's my source of nausea. And then always considering goals of care, right? And in some cases where nausea is refractory, it might be very appropriate to have further investigations. So your patient might want to consider blood work or imaging. If we're not able to reverse this nausea, there may be some interventions that are born out of blood work or imaging that could at least give us a little bit more information, right? So if, for example, I had a patient who we just weren't getting there, right? We covered the oral care, we got their bowels moving, we've slowed down their diet, we're trying our first line, maybe trying our second line, and we're just not getting there. I would consider some blood work. Perhaps there's some underlying metabolic changes that could be reversed. If imaging's an issue, I'm looking at obstructions, things like that, that could be contributing. Is there any questions or anything about nausea before I move on?
Nothing's come up in the chat just yet, but I was wondering, coming back to your first point about administering antiemetics regularly. So that means not PRN. But I bet in a lot of charts you'll see Q6H PRN or Q4H PRN. Do you have any suggestions? Like we just go ahead and give it every 4 hours, recognizing it's really important to give it regularly because as long as the cause isn't gone.
Yeah, I think it would also be super reasonable to flag, like if you're giving it twice in a row, to then flag it to the prescriber and maybe get that order changed or think about what's next, or have a conversation about, is there something else we can be looking at? Because if we're not critically appraising why the nausea is there, then we may be chasing our tails a little bit. But yeah, it's hard. And so the other thing we see commonly is just a standing set of orders, right, for every resident. And that order may be gravel 25 to 50, PO, Q4H, PRN kind of thing. And again, gravel is great. It has a role, but it just may be that we need a little bit more to sort of think, you know what, this nausea is caused because we just started an opioid. Adding some gravel on to combat that's going to compound some of the drowsiness that this patient's having. I wonder if metoclopramide might be a better choice. Pop it on for 48 hours and chances are after that you'll be able to switch it over to PRN as they get used to the opioid.
Thanks, Mel. There's been nothing else come up.
Okay. All right. I'm going to move on then, and hopefully, I mean, we're all, like, I know we're all healthcare professionals here, so constipation is not going to faze anybody who's probably eating their dinner during this session. I always have to put a little humor in there, right? I talk a lot about bowels every day. I'm on it with people. So this is just a cute little cartoon, and I'd love to know how many sticks of dynamite it will take for them to get their clients' bowels moving. So constipation refers to an infrequent or difficult to pass bowel movement. And this will represent a change from the patient's usual bowel function. So if a patient usually has a regular bowel movement every morning, and all of a sudden they're on day 3 or 4, you're looking at constipation. So if a patient goes to the bathroom every second day for their last 20 years, and they're on day 2 of no bowel movement, this might be a normal pattern for your patient, right? So it represents a change from the patient's baseline function. The reason for constipation is it's a slowing of the bowel motility. So you know your large bowel does this peristalsis and moves that food and resorbing water stool through. When that peristalsis slows down, it takes longer for the stool to traverse the colon. The longer it sits in that large colon, the more water gets sucked back into the body, drying out that stool further. So not only is it a slowing of the bowel movement, but the stool becomes quite hard and difficult to pass when it gets down to the final destination. Constipation can contribute to pain with defecation. So those stools can be hard and painful, which further creates some fears around going to the bathroom. Bowel movements that take 30 minutes, 40 minutes of sitting on the toilet can increase risk of fissures and hemorrhoids and all sorts of discomfort. So there's a ton of reasons to be constipated. But I think the biggest culprit that I see on a daily basis, bar none, is related to medication and more specifically opioid medications. So that's your morphines, your hydromorphones in particular. Other medications will contribute. So things like Lasix or your diuretics. When you think about their mechanism, they're trying to get rid of excess fluid. When you get rid of excess fluid, things are dry in the gut as well. Anticholinergic medications, again, same thing. We're trying to dry people up sometimes with anticholinergic medications, particularly around the end of life. So things like glycopyrrolate, for example, that will dry what's in the colon as well. Other things, antacids can also slow down the movement of your guts. Immobility. This is a big one as well. When patients are no longer moving around as much, they don't have the benefit of gravity. We also know that moving and engaging our muscles helps with peristalsis. A good example of this is when you do an abdominal exam, listen first, because those are your real bowel sounds. When you palpate the stomach and if you listened again, you're going to hear the peristalsis. You're going to stimulate some bowel sounds there. So movement's very important in terms of normal defecation. As people approach the end of life, of course, we see this natural decline in food and fluid intake, which will decrease the volume of stool. However, and I will put a big caveat, that even with no food or fluids, the lining of the bowels will continue to shed. So, and I've heard a lot of different estimates, but I usually say about half a cup a day. And I usually hold my hand up like this to demonstrate to people about half a cup a day of stool may still be produced right up into the end of life, which means we need to address this right up into the end of life. But very commonly, when I ask, have your bowels moved? and a family member will say, oh, they haven't moved in 3 days, but she's not eating or drinking anything. And sometimes it's a tough sell to try and push the bowel regimen, so to speak, even when people are approaching end of life. Another cause, mechanical obstruction. So this would be like if there's a tumor, say, for example, in the colon or the rectum. So there's like a mechanical narrowing of the lumen that the stool has to come around. If that stool is dry and hard, it's very difficult to get past those narrowings. And sometimes, of course, obstructions can be full obstructions, so it won't get past, period. We have medical conditions, of course, that can contribute. So I talked about the bowel obstruction, but something like irritable bowels. IBS can be mixed into 3 groups. There's IBS-C, so IBS constipation, IBS-D, diarrhea, and IBS-M, so mixed, where people oscillate between diarrhea and constipation. Low potassium will lead to constipation. It's one of those things that goes hand in hand. Hypercalcemia, so elevated calcium levels, which we can see in certain types of cancer, particularly bone cancer, for example, or metastases to bones, certain breast cancers, and certain, squamous type cancers. And then some of our neurologic conditions, we can get a neurogenic bowel. I'm thinking things like multiple sclerosis, multisystem atrophy would be another good example, where the neurogenic bowel might just stop working, right? So stool is lost in transit. It gets all that fluid gets resorbed, and you're stuck with some pretty severe constipation at times. And then this is a big one, and I think not to be overlooked, particularly in a setting where people are living in a congregate setting. So it's these psychological changes that occur when you're no longer going to the bathroom the way we have for the last 60, 70 years, right? We push kids to get out of diapers and use the toilet and not have accidents from about age 4, and then to wind up back in this place, that's quite a trip, right? So whether they're incontinent or continent, sometimes our patients do have to use briefs if their legs can't carry them to the bathroom or to transfer to a commode. Even if they have to transfer to a commode, maybe a bit of stage fright, right? Like sitting in the middle of your living room on a commode may not be conducive to a satisfying bowel movement. People may just not be able to do that, right? There could be fears of pain. So if there's a tumor sitting at that in the rectum, or there's bad hemorrhoids or fissures, and every time you move your bowels, it comes with excruciating pain, then the tendency is to not want to move your bowels, right? And finally, I think sometimes we're just in a setting where we're rushed. We don't have a lot of time to spend with our individual patients if they're requiring assistance. So it may be that transferring them to the toilet and having standing beside them on the clock saying, we got to get this show on the road, isn't really conducive to a healthy bowel routine, right? So let's not underestimate that psychological portion. Again, we're going to assess. So you can use your OPQRST, but we're going to hone in, when was the last bowel movement? How was it? Was it easy to pass? I often say, did you have to work hard? Because I don't want people on the toilet for 20, 30 minutes straining. To me, that's an indication that things aren't moving well. Did it hurt to pass? How big was it, right? Like, we talking small, medium, large. Let's quantify what it actually looked like. In the more congregate setting, we want to ensure that bowel movements are documented during care. This is pivotal for when you're assessing. You need to be able to look back and see when the last bowel movement was, know that that's being accurately captured, and then the characteristics of that bowel movement. We'll talk about the type of bowel movement on the next slide using a chart, but we want to know the amount, what it looked like, and if there was associated symptoms, right? Was there blood? Was there mucus? Was it watery? Et cetera, et cetera. So when I talk about this chart, I'm talking about the Bristol stool chart, which is fairly well known, validated. This is like from type 1, which is like a constipated stool. It's these hard little golf balls or rabbit turds, as we sometimes say, all the way up to type 7, which would just be like water coming out. Ideally, a healthy bowel movement will be in that 3 to 4 range, right? So you have a formed, sizable log that holds its shape. We'll say it's kind of gross, I know, but if we can document using this, then it gives us more clues. So I remember changing briefs sometimes in my earlier years, and like you change the brief and the stool like literally falls on the ground. It's so round and hard. And if I documented that, yep, bowels moved, probably we're missing something, right? So it's really important that we document really well. The other thing I'm throwing in here, because I never want to not talk about this as a possibility, is what we call overflow diarrhea. So overflow diarrhea is really the body being super duper smart. So it's when a person's so constipated that their body is just desperate to get stool out. It will liquefy the stool that's sitting above that hard stool. So it liquefies and comes out around. It can be associated with cramping. So it might be cramp, 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 loose bowel movement that we think is diarrhea. A little bit of relief, but still a fullness is there. It's sometimes accompanied by tenesmus, and tenesmus is just that sensation that you're have stool in the rectum. And I always just flag this because if you have a patient that's been constipated, like no bowel movement for 3-4 days, and all of a sudden they're having these watery, mucousy bowel movements, they don't have diarrhea. They probably have overflow diarrhea. So what's really important is that we continue the laxative regime, right? In the home setting, which I'm typically in, patients will say, oh my gosh, I have diarrhea. I stopped my laxatives. And again, it's this very tough sell to say, ooh, I actually think we need an enema or a suppository at this point. But the common theme is that this is diarrhea that was preceded by a period of constipation. Okay. When all else fails, if your patient's on an opioid, the chances of them developing diarrhea outside of a pathology is very rare. It's such a constipating type of medication that if they're starting with some of this diarrhea type tendencies, I'd be thinking constipation first. Okay, so just a word about overflow. Ooh, let's see. There we go. So again, similar to nausea, we want to assess the abdominal contour. In people who are close to the end of life and maybe have cachexia syndrome, so that's that wasting syndrome that Emily talked about last week or last month, you can even sometimes see the contour of hard stool in the left lower quadrant. You can feel it sometimes for sure. It feels like a lump under the skin. It's often kind of mobile, so you can move it a little bit. It's not hard or fixed like a tumor would be. So you're looking at the abdominal contour. Are they bloated? Can you see some fullness down there? You're going to listen. So you're listening for bowel sounds. in the context of constipation, sometimes these bowel sounds are going to be slow, hypoactive, right? Because that transit time has slowed down for some reason. I would not be shy about doing a digital rectal exam, of course, with consent from your patient. But you can sometimes feel hard stool in that rectum, and that'll just tell you right then and there that there's an intervention that needs to happen. So a digital rectal exam is an important part of the assessment. And then looking for accompanying symptoms, right? So abdominal pain. Are they agitated? I swear it's one of the most common causes of agitation at the end of life are these people whose bowels haven't moved or haven't moved well in like 5 to 7 days. And you have an intervention, allow them to have a bowel movement, and they settle and die very peacefully. Do not underestimate the power of good bowel movements, right? Deliriums can be caused by constipation. So we sometimes see this where a patient's thinking is a little bit slowed down or they're kind of funny. During the assessment, you can suss out that the bowels haven't moved. Usually it's sort of on the longer end of things in that 5 to 7 day range. Getting them cleared out resolves the delirium. For sure, you're going to see a decreased appetite. You may have nausea. And in the case of bowel obstruction, where there's nothing passing through, that nausea can sometimes even develop into like a feculent vomiting. So where they're vomiting feces type material. Okay. I'm going to take a little pause for a sip of water. This non-pharmacologic is a good chance for you guys to type in the chat too if you guys have any pearls or tips or tricks for things that work for you or your residents. What I focused on tonight was sort of a focus on prevention, right? Like how can we get some habits that are going to allow our patients to have as good a bowel routine as possible. So optimizing food and fluid intake if possible. If possible. We know that people towards the end of their life aren't eating or drinking as much. So it's if possible. Encourage mobility. Again, if possible. We're going to optimize privacy, time, and positioning for defecation. So how can we make this as dignified as possible for this person if they're in a position where they're not being able to go to the bathroom on the toilet the way we have for like the last decades of our life. And it's also a really good chance to leverage some of your allied health services. So dietitian for sure, like dietary to help look at what we can give, OT, PT for positioning, and most importantly, in my opinion, are people who are providing the direct care, our personal support workers who are helping with positioning, helping with transferring, and really the people who are able to provide the most dignified care.
Nothing's popped up in the chat yet.
Okay, I'll tell you guys about one of my nurses then. Well, let me go through pharmacologic and then remind me, guys. I'll tell you what one of my nurses in the community gives to patients. She calls it the bomb. And it's different. So I'll tell you about it in a second. Our pharmacologic interventions are super important. And what I would say is that all of my patients and probably all of your patients will require a pharmacologic intervention for constipation as they approach the end of life. Okay, this is one that's not going to get by on prunes for sure, especially as we use some of these different medications that can contribute to the slowing of the gut. So in the case of opioid-induced constipation, laxatives are non-negotiable. If your physician colleague or nurse practitioner colleague writes a prescription for an opioid and doesn't include a prescription for a laxative, you hand it right back and ask for it, okay? It's a non-negotiable. There are different categories of laxatives. So there are stimulant laxatives, and this includes your things like Senocides. Senocot would be a trade name. And Bisacodyl. Dulcolax would be the trade name for this. So those are stimulant laxatives that cause the guts to turn a little bit to try and help move stool through. So it's a stimulant laxative. We also have osmotic laxatives, which are things like PEG, or in terms of a trade name like Miralax or Restoralax, for example. So that's the powder that you're mixing up. You want at least we usually say 200 cc's, I would say, to mix that up. And that's sort of the bare minimum. The patient needs to be able to drink it within a fairly short time frame. If they sip on it all day, it's not going to be effective. Lactulose is another one. So if your patient can't drink a cup of fluid, lactulose would be a reasonable osmotic laxative to turn to, because you're looking more at a tablespoon versus a cup of fluid. These are osmotic laxatives. Their role is to pull some fluid into the lumen of the gut to hydrate that stool and get it a little bit easier and quicker to pass. If patients aren't able to swallow, we're looking at things like rectal suppository. So again, we can use the Bisacodyl, which is their stimulant laxative. And sometimes we can get by with a glycerin suppository, which is, it acts as a lubricant in the rectum. All else fails, and usually by day 5 or 6, I'd be looking for an enema. So the most common is a sodium phosphate enema, The trade name would be a fleet, right? So administering a fleet enema to stimulate the bowels to move. It also pulls fluid into the lumen, and we hope for an evacuation of the bowels using that. And then if you're a community nurse or a community nurse practitioner and work with a certain nurse named Kathy, she does up for people what she calls a bomb. She also works in retirement as well. But she mixes applesauce. She'll take a bit of applesauce out of a thing. She'll mix it with prunes. So you get the prunes, the applesauce, and then she'll do a half scoop of PEG and mix that in as well and give it to them with some fluids. And she swears by it, and her patients think it's hilarious until they're on the toilet. No, they're usually pretty relieved once they're there, but that's her bomb. Things like prunes, pears also, they have sort of a natural chemical in them that works like an osmotic laxative, essentially. So it's not necessarily a fiber thing so much as an osmotic thing with those fruits. There's also bulk forming laxatives, and I didn't include them on my slide because we don't ever use them really in the context of palliative care. So a bulk forming laxative would be like a fiber supplement that you would mix with water and chug, and that's great for people who are up and moving around like me and you, who aren't necessarily taking opioids and things like that. But in our population where mobility is an issue, fluid intake is an issue, the motility of the gut is a big issue, if we were to give them a bulk forming laxative, it'll just turn to cement. They'll never be able to move it through, and we'll be really up the creek if we do that. So if your patients are on opioids, they should not be on one of those fiber-containing laxatives. An example of that would be something like Metamucil or Benefiber.
So Catherine pointed out kiwi as well. She said some evidence
delicious.
2 kiwis per day for constipation management.
Okay,
Plus it is low FODMAP compared to prunes for those with IBS.
Okay, that's awesome. And they taste better too. Let's be honest. I've heard, and this was like a TikTok trend, not that I'm into TikTok too much, but dragon fruit, which I think would be very similar to kiwi and the way kiwi works. So eating a dragon fruit that's that white fleshy fruit with all those black seeds. And also the other thing that I saw a lot like last year was chia seeds. So mixing chia seeds and water, and they become quite gelatinous. And then I think the mechanism of that would just be that it moves through in this gelatinous way through your gut and cleans you out a little bit. So I like kiwis though, and they're delicious.
Aaron Prentice is talking about watermelon, and I can tell you, if I was sick, I'd go for the watermelon over the kiwi and the somebody asked, and I don't know if you've had any experience with this in long-term care, but have you ever worked with teams that have tried to support residents who have a psychological fear of going to the bathroom?
I personally have not, but I think I will be that patient someday. So I really empathize. I empathize with the patient quite a bit, and I also empathize a lot with people who work in a setting where they're not supported to take the time, truthfully, right? Or it's not, the system isn't always set up to help people succeed in this kind of thing. So I have not. I think that would be such interesting work. Just a whole lot of love on my end though for the patients. I can't imagine what that must be like for them, but and also for all of our amazing care providers, how hard it must be to not be able to always provide that type of care.
Aside from more fruit like papayas, we're good
Ooh, I like
going.
Yeah. And again, I think like when we look at on a macro level of prevention for all of us, like we're looking at good habits there. It's so hard. Our patients don't eat much, right? So if I'm looking at someone who's now not able to swallow, I'm starting to think, oh, they haven't moved in like 5 to 7 days. I'm going pretty much for the rectal suppositories, and I'll try that once a day PRN. But if I'm going another 2 days, I'm going to that fleet. And again, all of it for me, I find is a negotiation with the family too. Recognizing that those are invasive measures, but will probably spare some of the patient discomfort and medication use to combat that discomfort. So, okay, so here's our pearls. Constipation in the context of palliative care is rarely transient. So what that means is if your patient's constipated now, they're going to be constipated from here on in. So let's get a good regime in place, right? So for me, my patients are generally on the Senosides because I really think most of my patients need that push, that peristalsis, so they could be up to 4 a day. I often have them on an osmotic as well if they can tolerate that volume of fluid. If day 3 occurs and no bowel movement, it's a suppository, a stimulant suppository. And that's once a day as needed. If we get to day 5, I'm onto the fleet. So I have like a sort of a set plan that I try and implement with my patients. Opioids plus laxatives equals better BMs. Prescribe it always together, and don't hesitate to reach out to your prescribers for your patient's behalf. If they're prescribing an opioid, we really need a laxative with that as well. Constipation will usually require multiple types of laxatives. So you'll need to look at the different types of laxatives that we have and pick 2 different types. So I would never order 2 stimulant laxatives, for example, or 2 osmotics. I would do a stimulant plus an osmotic. And then finally, just don't underestimate the importance of managing constipation. It can be a huge symptom burden for patients and their families right up until the end of life. Any questions from constipation? Well, I have a little sip.
Victoria just asked if you could repeat your regimen that you just.
Oh, yeah, for sure. And again, this isn't medical advice. This is just to give you an idea. I would say I would use Senasides. Trade name would be Senacot. 2 tablets BID. So 2 tabs BID. I would use an osmotic laxative. So PEG 3350. The trade name for that would be like Restoralax or Peglax. And I would do 17 grams in 250 cc's of water. So 1 cup of water once a day to twice a day, depending. Not PRN, once a day for sure, maybe up to twice a day. If on day 3 there's no bowel movement, I would do a Biscadil suppository once a day. And then if no bowel movement on day 5, I would administer a fleet enema. Again, I might tailor that a little bit to the patient. So if this patient for the last 40 years or the bulk of their adult life only went to the bathroom every 3rd day, then I would adjust that. Yeah.
And I'm pretty sure, would there be anything like aside from those bulk laxatives that you would say people need to stay away from? From a dietary point of view, I would imagine it's what they can tolerate.
Yeah, for sure. Like, everybody's like diet's so different, like what people tolerate and what they don't. So I don't ever really have restrictions on diet, truthfully. The bulk forming stuff is a no-go. Anything that would act sort of, if they're really constipated, as like a diuretic, like say if they're drinking 18 cups of coffee or something silly like that, I might say let's cut the coffee a little bit, or so that if they're getting dried out from what they're putting in. Sometimes artificial sweeteners can be constipating, stevia or sucralose, stuff like that. I might try and avoid that if I suspect it's contributing.
We got a couple more here, and I know they're your jams. So asking about digital evacuation or high enemas, when would they be required, and would there be contraindications to that?
Yeah, so I guess like when you say high enema, I'm assuming like a high volume, like a soap suds or something like that. That's going to go up pretty high. I think all of it, even fleets, are going to be based on patient comfort and what they can tolerate, right? Fleets are fairly low volume, and I find that they're generally good enough to get things stimulated. A contraindication, though, would be I would be reluctant to put anything in there if you have a patient that has a tumor in the low rectum or even the high rectum, right? When you think about the length of the rectum being, say, 10 to 15 centimeters, I don't think I'd want to stick my finger up there just in case, right? So I don't think I would be putting anything up. That would be a conversation I would be having with the prescriber, the most responsible provider. In those cases where I'm worried about a tumor in the rectum that eventually could obstruct, my goal is to keep from the top down the stool very soft so that it just slides around like a loose almost, right? Because once it hardens up, it's not going to come around that tumor. So, so contraindications, just to recap, would be known pathology in the rectum. I would probably be very reluctant to stick something up there. If your patient is having chemotherapy, this is another important one for people in active treatment. After chemotherapy, there's what we call a nadir. So where the white blood cell count really comes down and people are quite, well, their immune system shot during their nadir. We tend to avoid suppositories or enemas during that time as well. So that's very specific to treatment, but I'll put it out there to the crowd that that's something I would avoid as well. And then finally, if my patient had like a blood-borne cancer where I knew their platelets were really in their boots, I'd be I would be very gentle or very weighing the pros and cons of inserting things into the rectum just because of the risk of bleeding for those patients. So your acute leukemias would be the one that would flag me as like maybe not wanting to put something up.
One last, there's been a few things, but we'll do one more because I know you've got two other topics you want to cover, and we've got about half an hour left. So
Yeah.
somebody said they don't stop giving the Laxaday as long as the resident can tolerate liquids, and they might even administer it with a syringe. Asking what your thoughts are on that.
Sorry, can you repeat that?
So
just the beginning
it's
part.
the Restoralax,
Continuing
I'm
the
imagining mixed in liquid. And so as long as they can tolerate fluids, but
Oh,
maybe
yeah.
not swallowing, but they might use a syringe to provide it.
I think as long as they can swallow it, you can certainly try. If you can syringe in that 200 cc's, that's fine. Like the beautiful thing about Restoralax is it doesn't change the flavor. You could mix it with water, you could mix it with juice, you can mix it with pretty much anything. The key is, can they swallow it safely?
And what a nice segue into your next topic.
I know. I think there we go. And I know Emily really did such a phenomenal job of talking about this. I really loved her presentation last month. So I decided not to go too in depth because the RD is like, she's a pro. But we see dysphagia in all of our patients. And this would be like our patients, for me specifically, I'm talking about in their final days of life, right? All of my patients lose their ability to swallow as they approach the end of life. So dysphagia is difficulty in swallowing. There's two different types. So there's an oropharyngeal dysphagia. So like oropharyngeal is like up here, right? So it's difficulty initiating that swallow. And then esophageal dysphagia, where the difficulty is in the second phase of the swallowing. So from, here to here along that esophagus, and food just doesn't go down the pipe properly, I guess is the best way to say it. It often makes people feel like they have food stuck in their throat. This dysphagia results from like mechanical processes, so like esophagitis, thrush, mouth sores, really severe reflux even, for example. There's also neurologic processes, so our patients with dementia, for example, or MS or MSA, Parkinson's, where the signals from the brain aren't coordinating well with the muscles anymore. And then for a lot of my patients towards the end of life, it's a fatigue thing. Like they just don't have the energy anymore. So we'll see dysphagia in a lot of different trajectories, and it's almost 100%, 99.9% guarantee as people approach the final hours and days of their lives. So again, I'm probably preaching to the choir, but we do have a high prevalence of dysphagia in dementia, and it can often signify these patients may be transitioning into a final phase of their life. So dysphagia is at the end of life is also influenced by medications. Certainly some of the medications we use may have a side effect of increased drowsiness. Patients are more sleepy, so that, again, they just aren't able to waken up enough to coordinate the movement of swallowing. There's increased time asleep, so their awake moments are becoming shorter and shorter, so the opportunity to allow them to swallow is shorter and shorter. And then, of course, there's a loss of fine motor function. The brain is too tired to communicate to these muscles to coordinate all the intricacies of swallowing. it just becomes too much work. So the return on investment from what they get from swallowing, which would be what we would hope is energy maybe or pleasure, it's just not there anymore because it just takes way too much work. It's easier not to, right? That's how I like to think about it. In terms of intervention, if there's a reversible cause and if it's appropriate, we can try and reverse it. So something like thrush, of course, like to me, I would say, yeah, let's treat that. At the very least, they're going to be able to receive mouth care or swallow things with just a little bit more ease if we take care of that infection. Xerostomia, so that's a fancy word for dry mouth. We can replace saliva. We can do really good mouth care. We can have people suck on lozenges if it's appropriate to stimulate some saliva. That's a reasonable intervention to help people swallow a little bit longer. Treatment of GERD, right? So if somebody's refluxing, they have esophagitis, then I think it's very reasonable to treat that GERD in the hopes that A, better symptom management, but B, that it might make swallowing a little bit safer and easier. We can look at dietary modifications. So, puree, mince, thickened, nectar thick, positioning and assisting patients to good positions if it's appropriate. And then also looking at environmental considerations. So if I have a patient that's like having a harder time swallowing, I try and decrease some of the stimuli. I might not have them eat at a table with people, or I might say to the family, now isn't the time for a big conversation about how the day was or whatever. We're just going to focus on eating so that the patient's not trying to eat and chat at the same time. Looking at getting rid of some medications. So if it's hard to swallow pills, what can we get rid of, right? Like, do we still need to be on that cholesterol medication? Do we still need XYZ vitamins and all that stuff when it's so hard to swallow? So I would always be looking at deprescribing. Alternate routes of medication administration. So when I get the word that things are getting a little dicey with the swallow, I want to make sure we are set up for success. Do we have injectable medications available to us? Because at some point we're going to have to transition, and we want to be able to have medications for symptom management available. And just a note that enteral or parenteral feeding is rarely of benefit in my population. So in advanced disease, we're generally not going to see benefit from things like TPN or feeding tube insertion, etc. That's it for part 1. 8:10. We're in good shape here, guys. But my mouth is super dry, so I'm just going to have a sip. Okay. Anything coming up before I move on?
There was only one more thing related to constipation that I missed.
Yeah, no problem.
A sodium phosphate enema versus a mineral oil enema. Do you want to comment on that?
Ooh, I haven't seen a mineral oil enema in ages. So for me, it would just be what's available at the drugstore, truthfully. 2 different mechanisms. The mineral oil is going to lubricate the rectum and anus. Probably by virtue of putting fluid up there, it's going to stimulate a little bit for some peristalsis, maybe in the lower bowel. Whereas your sodium phosphate's going to do that, plus pull in some fluid into the lumen. A mineral oil would not pull in fluid to the lumen of the lower gut. I do remember soap suds enemas from nursing school, and it was a big old bag with soap.
Oh, yeah.
Like, I don't know if they still do that anymore. I haven't worked in a hospital for like 25 years. So anyways, yeah, great questions.
And Lana just offered pure mints for dry mouth. So they have xylitol in them.
Yepper. I'm writing it down. They sound a little bit similar to xylee melts. I don't know if you've seen xylee melts. They're like a little tablet and you actually just put it up. It's like chewing tobacco when you put it up. I mean, not that I know what chewing tobacco is like, but you would stick it up on your gum and it just stimulates the mouth to salivate a little bit. So Xylem, same thing, xylitol. Quite good. Yeah. Okay, I'm going to move on. So again, I know Emily in her presentation talked a lot about this. And for me, when I'm working with patients who are losing their appetite, often my patients truthfully are losing their appetite before they lose their ability to swallow. None of my patients really are eating very much. So I always try and distinguish between hunger, which is the physiologic process that happens in our body that signals us to eat, right? So chemicals are released that signals in our brain, okay, it's time to reach for something, because if I don't, my energy's gonna run out, I'm gonna bonk, right? Whereas appetite is more of an emotional process. It's like that desire to eat. So it comes when we get hunger cues. We certainly have an appetite when we're being told, okay, go eat, like your stomach's telling you. But appetite can happen in the absence of hunger, right? So if you see like a commercial for the keg and your mouth might start watering, right? So the visual of that big juicy steak may stimulate your appetite. So I often think hunger, biologic, appetite, emotional, right? It's stimulated and mediated by emotional things. And again, for various reasons, my patients rarely have an appetite. Food just isn't stimulating the same way. And I think it's just because the body and the brain are super smart. They know putting a steak in is going to require so much energy and work to digest and eat that they're going to be done for the rest of the day. They'll have a stomach ache. They may be nauseated because they overdid it. Their body's just saying, no more, no more. Food, fluids, and appetite. So food, of course, is a source of comfort. We often use food to improve our quality of life. When we share food or eat food, it can evoke memories. It's a shared experience. So I put a picture of my kids at the kids' table at Christmas because for me and my family, it's these holidays where food is sort of a central thing. We all sit together and we feast, right? Intake of good food also gives us a bit of a dopamine hit sometimes too. Culturally, food is very important. As I mentioned, and for me and my cultural beliefs, we eat at Christmas, we eat at Easter, we come together as a family. Even though I'm fairly non-religious, it's just what we do. And we sit around the table and we laugh and we drink and we eat. And food is really a way of caregiving. So for my mom, who produces all of this food and puts it on the table for her kids and grandkids and friends and family, this is her way of showing caring, right? When someone gets sick, we go to the door and we knock, sometimes with our soup to offer. When someone dies, we show up with groceries, right? So food as a part of our culture is huge. And certainly as the natural process of heading towards end of life decreases our appetite and our hunger, our caregivers are very concerned, right? So words like starvation and dehydration are sometimes at the forefront. So that's a little context in terms of why food is important. Now, we have natural changes that happen, right? We all see it and have experienced this with our patients or our residents. So part of the reason our appetite changes is as we approach the end of life, or even as we age, our sense of taste and smell changes, it declines. Often our patients need much more flavor, salt, sugar. They tend towards stronger flavors, and that's just because that's what their taste buds can sense. Our patients also have a very slowed down metabolic rate. So their need to intake calories goes down. So the hunger cue is driven less and less and less by those biological cues. There's also a slowing of the digestive process, right? So the mouth is dry, the stomach's not going to empty into the bowel as quickly, which can cause discomfort, and the peristalsis is decreasing as well. We also can see what's called a cachexia syndrome, which is, well, we used to call it a wasting syndrome, and it's a condition you could actually test for, but most of us can identify it even just by looking. So this is when there's catabolism that happens. So the muscles start getting used up. There's very little adipose tissue. It's very classic in patients with cancer, advanced heart disease, advanced COPD. And generally what happens is it just results in decreased perfusion, fatigue, decreased hunger for sure. And then there's also a lot of biologic changes. So if I took blood work from these patients, you're going to see increased inflammatory markers, which is sort of a hallmark for cachexia syndrome. Cachexia is a poor prognostic sign. So it's a little bit of a clue that we need to have a conversation or transition if you haven't already, as this patient may be approaching the end of life. And often for these patients who, although they're not hungry and they don't have that appetite, and they can tell their loved ones till the cows come home that they're not hungry, this loss of appetite is distressing. It is so distressing, sometimes to the patients, but a lot of times to the caregivers. And I often just say, you know, even if you ate an extra large pizza every night, your body just can't use that food the way that you need it to. These patients will not restore their weight regardless of what they put in. So in terms of like, how do we can't really intervene on this natural decline in intake, right? But there are some interventions that we can do to ensure that the patient is more comfortable and hopefully the family is more comfortable as these changes are taking place. So we look a lot at mouth care. So ensuring that the mouth is clean, it's moist, teeth or dentures are taken out and cleaned and put back in if that's what the patient wants. We use a lot of saliva replacement, so the biotines, etc., just to keep the mouth moist. We use mouth swabs. If you don't have access to mouth swabs, I usually send a family member out to Dollarama and get baby toothbrushes because they're nice and small and the bristles are really soft for the patient's mouth. And lip balm, just to keep their mouth really feeling good. We talk a lot about eating for pleasure. So offering really small amounts of food that will make the patient feel good, and feel good not because they're hungry, but feel good because it reminds them of something, right? Or they're like, oh, a little melt of chocolate and they're thinking about Valentine's Day or what, you know, something like that. So we're eating for pleasure. I often tell my patients food is for pleasure and quality of life and not nutrition. I have zero concerns about nutrition at this stage of the game. This allows the family as well to sort of switch gears too, right? So they're less worried about getting the supplements in, the boost in, making these big protein smoothies, and more about what's gonna just give a little small pleasure to their loved one. And then because we know that sharing and preparing of food is really important to caregivers, let's redirect and find other ways for those caregivers to provide and connect to their loved one. So that might be doing some skincare, like cream on the hands and painting nails, or foot massage or foot rub. Maybe it's reading out loud to their loved one or playing music. We just need to find a little bit different way of connecting. If previously they were connecting over food and feeding. Just a quick word on hydration. IV or subcutaneous hydration may have a role in limited circumstances. Like for situations where patients experience intractable nausea, if it's a short-term intervention to see if we can ease the symptoms of something bigger, like a bowel obstruction or an opioid toxicity, then I think IV or subcutaneous hydration definitely has a role. You really have to look at if the risk of giving a patient who's dying fluids will outweigh the benefit, right? So the need for fluids at the end of life is very low. So in terms of what we're putting in with hydration, if we choose to go that route, we're looking at very low rates, even as low as 10 cc's an hour. I worry a lot about patients getting a bit overloaded. So if a patient already has some edema or has heart failure in the past and has had some pulmonary edema, if I put more fluids in, then I'm risking stimulating that or making that worse. And it is interfering to some degree with the normal dying process, right? Our bodies are really smart to slow down the intake of food and fluids as we approach the end of life. And adding fluids in might be interfering with that. And we do risk creating some symptoms that we then have to treat. So that was just a little word about hydration. So in terms of navigating these with families, I was hoping just to give you a few liners, and literally like when I hear someone say something and I'm like, oh my God, that was awesome. I just write it down and I remember it next time and I use it. So if this is helpful for you, that's the goal here. So it's normalizing the process. It's our job to teach the family who maybe have never been through this before. Certainly you only have one mom to lose or one dad to lose in most cases. So it's the first and the last time for that. It's monumental, pivotal. So I try and normalize the process. So I might say something, I've noticed that your mom's appetite has been declining for the last several months. We see this commonly as people are slowing down. And that might be an opening to a conversation around what the family might be feeling. Or if the family comes to you and says, she's not eating anymore, she's losing weight, right? This could be a response. So again, if the family comes and says, you're not feeding her, we're gonna, she's gonna starve to death. I think that's a very realistic thing that people say. You might respond with, it may be that your mom isn't able to eat and swallow safely anymore. I'd like to tell you about what options we have to make sure we maximize how she's feeling, even if she isn't able to eat with us. Again, it's just normalizing and opening the conversation. Saying to the patient, and I often say to the patient, it's okay if you don't feel like eating. Food just isn't what your body is needing anymore. Let's focus on things that make your mouth feel good, right? And finally, I think this might actually be my last, nope, it's not. I'm watching the time, believe me. Keeping an open mind about families, but also about your colleagues, right? We all come with a different lens, and having a patient not eat or drink anymore can be upsetting to even your colleagues, right? So just keeping an open mind, approaching with curiosity. Things like, I can see how hard this changes. What bothers you the most? And that might open up a conversation about their grief or what they're missing, where you can intervene with maybe offering some alternatives, right? Going back to like, here's what you can do. Do you have any spiritual or cultural beliefs around eating? Can you tell me more about this? So it's having that conversation, what might be needed for the patient and family to be more comfortable with this. I can see how worried you are. Tell me more. All of those sound really corny on paper, but I promise you they work. Like they work. People just need that invitation. and permission from you. So this was I tried to come up with some responses to she's going to starve to death. I always use Wish, Worry, Wonder. And if you don't know about Wish, Worry, Wonder, it is one of the best tools in my arsenal. So if you Google Wish, Worry, Wonder, you're going to come up with a treasure trove. I promise you that. So I would say I wish that our residents could continue enjoying food right to the end of life. But I worry that if we try and feed or force or hydrate interchangeably, we could cause some more discomfort. I wonder if it would be helpful to know what changes we might see in the coming days and weeks ahead, right? So it's validating, but it's also offering an alternative. It's opening that conversation. And sometimes I also just say, this is so distressing. Just like that, this is so distressing. Many of our residents don't feel hungry as their body's slowing down. I can review with you how we will make sure she's comfy as she approaches the end of her life, right? Validating, normalizing, and offering the very active care that is palliative care. So I'm not sure if anybody had questions, or I'm pretty happy to answer anything, or if anything comes up. Again, I can't see the chat, so.
Well, people want you just to keep talking. They
Oh.
don't want the presentation to end.
You know, it's a problem I have, Val. I talk a lot, and I could talk a lot about, I could talk here all night about things. So I won't, though.
Victoria had a quick question about markers for cachexia. Like if you were to do blood work to check for cachexia, which
Oh, yeah. So yes, and I like off the top of my head, I can't give you the specifics of what you would write down on the requisition, but you're looking at things like I'd have to look at it. I could put it in the chat for you. Give me 2 seconds if you want.
Sure.
Off the top of my head, because I honestly have never done blood work to look for markers of cachexia.
Okay.
Yeah, I don't try. I don't get bent up on restoring weight. However, our dietitians and like TPN teams and things like that are quite specialized at that. And they know, they can differentiate between if a patient is losing weight because of like a malnutrition or undernutrition versus a cachexia syndrome.
Melanie, I just want to, there's lots of amazing kudos going through, but you are a natural, and I just so enjoy listening to you and always picking up some pearls from the wisdom that you share. So on behalf of everybody, we want to thank you so very much.
Awesome.